Good morning, everybody. Welcome to the Health and Overview Scrutiny Committee. I'll just take you through, as a committee, some of the key points of how we will run the meeting, and then we'll move forward. So we're running the meeting, as you can see, on WebEx. I can see most of you on a screen. I can see 9 at a time, but that's not everybody. You have a facility for raising your hand if you wish to ask a question, and I can see that. But if that's not working for you, by all means, wave your hand and hopefully I'll pick that up. Or if all of that fails, do interject, and we'll try and make sure that everybody can take part. So is everybody comfortable with that? We'll move on. So first of all, are there any apologies for this meeting?
I have no apologies. No formal apologies have been received, Brian.
Okay, thank you. And
I have an apology from Councillor Nigel Robbins, who can't make it.
Thank you.
Thank you. And are there any declarations of interest relating to items on the agenda? Can't see anybody indicating, so we'll take that. And then thirdly, we'll go on to the minutes of the last meeting. Does anybody have any concerns or corrections that they wish to make to the minutes of the last meeting? If I don't have any points raised, I will take that as a confirmation that...
Martin's waving his hand, Brian.
I've waved my hand and I've raised my electronic hand. But
okay, sorry, Martin. Obviously, it's messed it already. But,
Thank you, Chair. I just want to raise a point of order about the agenda before we progress much further. Clearly, this is the county's health scrutiny committee, and it seems wrong to me, especially since there is quite strong anecdotal evidence now of some kind of second wave getting quite strong in Cheltenham, certainly, and I guess perhaps the rest of the county, that we don't have an agenda item to look at the current NHS and other health services response to COVID-19. Now, clearly, we can look at this in terms of the work plan, but that's a long-term document. We can look at it in terms of the temporary service change under item 6, but that's actually a specific organisational topic, which doesn't really address the immediate short-term issues which might be, for instance, to do with advice to close schools or how well track and trace is working locally. These are really crucial issues, and they are clearly, I mean, it's the biggest health issue we've ever faced. So it seems right that a health scrutiny committee should look at them. And I wondered if we could have an additional agenda item just to hear perhaps a short summary from the Director of Public Health, who's attending the meeting, just on what the situation is and how we're expecting to respond to it.
Thank you for that point. I had a think about this. I do understand the point that current issues that are developing are something that would be of interest to committee members. But we do have another committee that also looks at public health, the adult care, which met only last week and had a detailed report. What I will do is allow you to bring your questions forward when we are talking about the temporary service changes, because that is the topic related. And that would give an opportunity for the Director of Public Health and the Cabinet member, if they wish to answer the questions that you wish to raise on the current crisis. Okay, so, and we'll also come back to it at the work plan at the end of the meeting to see how we'd like to take that issue forward as a committee in future. So that's how we will pick up your concerns.
Thank you, Chair.
Thank you. Right. So I think we were doing the minutes, and I didn't have anybody raising any points, so I'll take that as an affirmative that the minutes are accepted. My next announcement really is on an additional Health and Overview Scrutiny Committee, which will take place on the 22nd of October at 10 AM. And that will bring forward the proposal for the Fit for the Future programme and also the changes in the Forest of Dean. Right, the next item we're going to come to is the representation from a member of the public, and we have, I believe, Marco Taylor, who wishes to bring forward some concerns that he's got. So can I just check that Marco Taylor is in the meeting?
Hello, can you hear me?
Yes, I can. Right, we've got technically 3 minutes, so if you can keep roughly to that sort of time, the floor is yours to tell us what your concerns are.
Thank you. I'll definitely try and keep it brief. So I just really wanted to raise to the committee my concerns and the concerns of the community in Cirencester about the changes to the provision of phlebotomy services, which previously were provided at the hospital in Cirencester, and then in mid-July were announced with no public consultation would be switched to provision at GP surgeries. And there have been two main impacts of this. The first is those with routine referrals for blood tests have gone from having access to a same or next day service at Cirencester Hospital to now waits of 2 weeks or longer for access to the same services at their GP surgeries. And for those who had a need to access blood tests related to hospital treatment, the GP surgeries are unable to provide this facility, which means a large number of patients are now needing to make additional journeys to Gloucester Hospital for this service. This is having a disproportionate impact on the most vulnerable members of our community because there is no direct bus service between Cirencester and Gloucester Hospital. And as I put in my written submission, in our local newspaper, an example of a lady has had to pay £70 for a taxi to have access to this basic service. I spent the best part of the 6 weeks notice we had for this change looking to engage with the CCG to find out what engagement had happened in relation to this and if they'd undertaken a quality impact assessment. This was only received some 8 weeks after I wrote in, well in excess of the time required to provide this information, and it was clear that the assessment was incomplete. No assessment of the needs of patients who had requirements for blood tests related to hospital treatment was undertaken. The impact assessment itself also readily acknowledged that there was no evidence base for the need for this change and drew its examples from studies in the London Borough of Barking and Dagenham and Barnet, which have got completely different needs and certainly levels of access to central health services such as in hospitals. And it also seems to refer to some issues with the provision of Cirencester Hospital which aren't echoed by the local community. There is a local petition with in excess of 3,000 signatures asking for some form of useful access to blood testing to be returned to the community. This is highly disruptive and, as I say, is impacting those who have got the least access to private transport the most. One of the main benefits that the Equality Impact Assessment said applied was there'd be no need to pay parking charges for Gloucester Hospital. I think that's a bit of a belittling attitude to the needs of those people, particularly with disabilities and reduced mobility, and also ignored the fact that there is free parking at Cirencester Hospital too. So, having tried to engage with the Clinical Care Commissioning Group and not got a meaningful response or acknowledgement why they failed to engage with the community, I'm asking this committee to hold that group to account why they've implemented these damaging changes to community health services and what's going to be done to return the level of service to what it was prior to the change.
Thank you, Mr. Taylor. This is a point where there's representation made, and the response is going to come to you on it today from Dr. Andy Seymour, who I think is here to respond to that.
Yes, thank you very much, Chair. And thank you very much for the submission and the question. And we have prepared a full written response, which we will publish later and send on. But I will paraphrase that response in terms of expediency. Just to set in context in terms of terminology, so we just understand what we're talking about. Community phlebotomy you can really describe as both primary initiated bloods and secondary care initiated bloods. So primary care initiated bloods, the vast majority of community phlebotomy where a GP sees a patient, decides that a blood test is required, then it organises the test. So we call that a GP initiated blood test. Then there are a few blood tests that are requested by secondary care, by the hospital usually, that may be done in the community setting. So often related to outpatients. So those are the kind of two terms we use: primary care blood, GP-initiated blood, or secondary care-initiated blood. In terms of the background, for the last couple of years, we've been looking at the provision of community phlebotomy across the county, being well aware that there's an inequitable provision. For instance, in Forest of Dean and North Cotswold, for example, all community phlebotomy has been provided out of the GP practices, whereas in other parts of the county, for instance, in Cheltenham, a lot of these bloods were being done in Cheltenham Hospital. And we were getting some concerns from patients about the lack of localism for this provision. We did do a lot of engagement with the public, particularly with the PPGs of practices. And this message was kind of confirmed that they wished for provision of this service to be done more locally. There was also increasing comments that there was pressure on the hospital service when patients attended for these blood tests. These blood test services were drop-ins clinics, and sometimes if there were too many people were turning up, it would put a lot of pressure on those services, and indeed sometimes would have to close early. So again, providing a not satisfactory outcome for these patients. So we felt we had a clear objective to provide changes to try and equalise provision across the county, to look for a local setting in GP practices, to look for a booked service, and as I said, provide an equitable service county-wide. And that was the background for the changes. Specifically in terms of Cirencester, we recognise that there probably has been a greater impact because of the provision previously occurring in Cirencester Hospital. But all practices in Cheltenham are now providing phlebotomy services for their patients for all the GP-initiated requests. And there is still indeed a provision of secondary care-initiated blood tests at Cirencester Hospital currently on a Monday, which is a booked service. And we recognise that we need to look at perhaps expanding that from a system-wide perspective more than just on a Monday. We'll be looking at developing that over the coming weeks and months. I'm happy to report back in due course on that. Lastly, in terms of waits, I do recognise that there might be a slightly longer wait at present in primary care for the blood test, but unfortunately, it's coincidental that these changes were made during the COVID crisis, and there are increased waits for phlebotomy services right across the county. And we've done a survey of some of our practices where GP practices were providing phlebotomy last year as well. And the average wait there last year was 2 or 3 days. Currently, it's 2 weeks, and that's because it takes much longer to provide at the service for each particular patient because of the needs of COVID and cleaning rooms and so on and so forth. As I said, happy to submit the fuller answer in due course. Thank you.
Thank you, Dr. Seymour. Yes, Mr. Taylor, we won't. The item on this agenda is for you to raise the point and you to have an initial response. The committee will have heard your concerns and the response, and may well wish to bring it forward for further discussion at a future date. But at the present time, it's not an agenda item that we'll be discussing today. But thank you for bringing the concerns to us, and hopefully you'll find the full written response of someone. Would you like to come back briefly? Yes.
I'd just like to make one very brief point, and that I feel it's particularly unfair that the needs of Cirencester have been bundled together with those of Cheltenham and Gloucester when it has very distinct needs, and the issues identified around early closure of clinics were all experienced in Cheltenham and Gloucester and not in Cirencester, and none of the data has been pulled out to separate the distinct needs and natures of the communities involved.
Thank you. Well, we've heard your points, and we will therefore take them forward as the committee sees fit. Thank you very much.
Thank you.
I can't see anybody raising a hand on that. Is that correct? I think that's probably yes. Paul, you wanted to come in.
Yeah, sorry, I was just trying to unmute myself. Yeah, I just wanted to thank Mr. Taylor for bringing this forward. I think it is a big issue around Cirencester and the Cotswolds. So what I would simply say is, could this be? I'd like to bring this to have this as an agenda item for the next meeting, please. I'll just sort of flag that now. I know we've got the work planning agenda item later, but I think it's important that we scrutinise this further, because I also have a lot of concerns for my constituents around there. So I'm just putting that marker down now. Thank you.
Okay, thank you. And thank you very much, Mr. Taylor, for bringing it to our attention. Right, we're going to move on then to the items we've got on the committee. So the first on the agenda. So the first item is looking at winter planning, and we've got Maria Metherall who's going to present on that. So over to you, Maria.
Good morning, everyone. Morning, Chair. Thank you for inviting me to talk about the Gloucestershire Sustainability and Surge Plan for 2021. Can I just check that the presentation can be brought up and I can then request click through? Is that something that's available to me?
Joe, are you able to provide for the presentation to come up?
Joe still seems to be muted, but I can just say that we haven't been sent that request wasn't made, so we haven't got that ready at the moment and available. But it's going to take us a couple of minutes.
If you've got it on your PC, you can share your screen, so it will do it that way.
Yeah, from you, Maria.
Yeah, I haven't got it on the screen. Sorry, I should have prepared for this. I've just come back from leave, unfortunately. Okay.
Did it go out with the papers? If it went out with the papers, I can share it.
Could you share it for me, please, Margaret?
Let me have a look and I'll find it.
It's Becky. If it's helpful, I've got it. I can share.
That'll be useful, Becky. Thank you. Thank you, Becky.
Yes, we can see it now.
Lovely. Becky, happy to scroll up to the top for me, please? Lovely, thank you. Okay. Oh.
You need to turn off one of your devices, Becky.
Yeah, we've got all our speakers off in this
room.
room. Okay. Right, okay, I think we're ready to go. Apologies for the delay there, and thank you very much. As I said, I'm Maria Metherall. I'm the Senior Nurse for Urgent Emergency Care in Gloucestershire CCG, and have been responsible with colleagues across our system in developing the Sustainability and Surge Management Plan for 2021. If I can ask you, as I go to click through, scroll down, that would be most useful. Thank you. Okay, so the Winter Sustainability and Surge Management Plan this year has obviously been developed with a significant challenge associated with the COVID-19 pandemic. And much of our planning has been very much focused around how do we plan for potentially additional demands, both created by a normal winter as well as COVID-19, also within a backdrop of reduced available capacity. It's also against a backdrop where we have clearly lost capacity across our entire system due to the COVID-19 pandemic. The way in which we've embarked upon the Sustainability and Surge Management Plan this year is very much aligned to the bronze COVID-19 cell structure. And we've given each of those cell structures responsibility for considering and planning for winter this year. Now, we obviously acknowledge that this plan, there are numerous possibilities of what could happen this winter. And so what we decided to do is look at 4 major scenarios and plan based on the potential for those 4 major scenarios. So we looked at, could we possibly just have a baseline winter based on previous winters? And I think as we move forward, that is now looking more and more unlikely. We then looked at what could we do around, based our planning around a normal winter with COVID levels around the levels we were experiencing during August and early September. We then looked at the third scenario, which was a baseline winter, but with high levels of COVID, like we experienced right at the very beginning of the pandemic. And finally, what if we had a winter, exceptional COVID levels alongside flu, norovirus, and other communicable concerns. So those are the 4 areas that we have focused on with regards to planning for this year. Thank you, Becky. So, as normal, obviously, we considered our key aims for winter 2021. This is very much aligned to the phase 3 NHS response to COVID-19. So first things first is obviously when COVID crisis first started, we made decisions to rationalise certain services, and very much the focus of this plan is how do we accelerate the return of those non-COVID-19 health services, trying as much as possible to maximise use between now and winter. We are obviously clearly eager to focus also on elective activity and resuming as much elective activity as possible, as well as restoring the return of primary and community services. Very much the focus, as well as expanding and improving mental health services with a key focus on learning disabilities and autism. And then finally, obviously, what this presentation is largely about is how do we prepare for winter with the possible resurgence of COVID-19. And within the plan, we've focused very much on sustaining current staffing, bed capacity across our system, looking at the seasonal flu vaccination programme, how we deliver on the Think 111 First model, how we maximise hear and treat and see and treat, which we know as a Gloucestershire system, our ambulance service deliver very well in that area, but we want to see that maintained and improved wherever possible, as well as continuing to use NHS volunteer responder services and working closely with council around managing discharge and supporting flow from all our bed-based services. Thank you, Becky. This slide is just a bit of a snapshot just to give you an understanding of how our bronze cell structure worked. All members will have received, I'm assuming, this presentation before this presentation. So that is just to reiterate the cells that have been working with me in order to develop the plan for this year. Thank you, Becky. So it is clear that we need to both learn from winter 1920 as well as the enormous amount of learning that we have taken from COVID-19. Now, the first 3 elements of this presentation is very much what we have learned by working as a system. And I think the overarching message that we have probably heard during COVID-19 is that we really now understand that by working as a system, the sum of our parts, we become more than the sum of our parts, and we genuinely, truly started to trust in each other, what each of our partners are able to support during such crises as the pandemic flu. The second 2 elements are around service transformation. And we truly transformed the way we worked. Just giving an example of virtual appointments that we've been using across primary care, the acute trust, and in many, many other service provider areas. And clearly, we've also embraced the use of technology. Today is an example of that, of how we're having meetings in a very different way, as well as the use of technology to support direct patient care. The next 3 around lessons learned are around behavioural for staff as well as patients. And I think for me, or speaking to many people, we definitely had to change our risk appetite during COVID-19. And we now need to look at what we learned from that and what we can safely and effectively maintain. And we also know that patient behaviours changed during that time. And again, we need to look at how those patient behaviours changed and what we can harness and take forward into this winter. The final three is very much around how do we make urgent care more planned? How do we get our system far more bookable? Right through to thinking about the new initiative around Think 111 and how we even make ED appointments within our system bookable. Speaking to teams across our system, one of the things that comes out very, very strongly is people were saying they felt the freedom and liberation to make changes. So they had a good idea and they made them happen. So again, how do we harness that freedom, acknowledging that we will still have governance frameworks in which to make those changes, but there was a real sense of freedom and liberation that we really genuinely now need to harness. And finally, how do we use staff and skill passports effectively to ensure if the second surge of COVID-19 does come at a time of a pressured winter, can we successfully move staff around our system in order that care is provided in the most needed setting? Thank you, Becky. So reflecting on the learning, the challenges are very much reflecting the fact that we now need to look at how we sort of influence patient behaviours following changes in clinical practice. How do we reassure patients that the consultations they are having that might not be direct face-to-face, but over the telephone are effective and successful in delivering their needs? And how do we continue to harness the use of NHS 111 as our main point of contact when we're uncertain as to what care we need and what best setting to go to? We need to apply learning throughout and protect some of those aspects of the communities, such as our care homes, which was where there was some clear key learning during the COVID phase 1. One of our major challenges will be mobilising schemes in a timely way. In the presentation pack, there are a number of schemes that we are looking to deliver for winter this year. I won't talk to them all, but I think one of the key challenges is how do we deliver all of those in a timely and responsive way. PPE, ensuring that we've got good flow of PPE across our entire health and social care voluntary sector. And as well, on top of this, is planning for any other potential impacting changes, such as the Brexit. We've got challenges around loss of productivity. Clearly, staff are now needing to spend time using extended use of PPE, as well as new cleaning regimes, and that naturally is going to reduce productivity, but for obviously very strong and justifiable reasons. We will be delivering care in an area where we have reduced capacity, our emergency departments and across our bed-based system. We will need to continue to protect our shielded and vulnerable people, and often that's through virtual means, which obviously is challenging both for the staff delivering that care, as well as clearly the people, the shielded and vulnerable people receiving that support. We need to plan for increased staff sickness due to self-isolation, as well as sickness and the normal winter sickness, as well as acknowledge that I think we are in a system where we have fatigue and change overload. So we need to sort of model that through when we are predicting how we manage the increasing demand during this winter period. And obviously, we need to prepare for the potential of a second peak. The last two is around ensuring we've got a resilient flu vaccination programme, which we can deliver within the required timescales and reflect the new and changing demand within that programme. And I think probably last, but by no means least, it is really genuinely about predicting the unpredictable for this winter. I think I've come to this HOSC many years now, and probably winters are very predictable normally, but I think we have to acknowledge that this year we will be predicting a very, very unpredictable system. Thank you, Becky. So I'm not going to talk to these slides. The only one I may touch on, if I may, is the Think 111 first, because I mentioned that earlier in the presentation. So I suppose it's just to say that one of the major schemes that we are looking at for this year is very much looking at how we use 111 as our first point of contact alongside primary care in order to ensure that patients, wherever possible, get the right care and support at their point of contact with the services. And very much part of Think 111 will be, wherever possible, booking patients' appointments where it is clinically deemed necessary. Unless there are any particular questions about the schemes I've listed, there are 17 in total. They are the ones that we are regarding as our high impact actions for this winter. And they are the ones that we have now modelled through into those 4 scenarios to identify the impact they are likely to have, both on our bed base as well as demand within our ED system. So unless there are any particular questions about any particular scheme, I'll ask Becky to scroll through to the next slide, please. Okay, I won't cover this section in any detail other than to say, obviously, part of our plan is around reflecting the temporary changes that have taken place within GHT. And I know that is an agenda item later in the HOSC agenda. So we'll not speak to that unless there are any particular urgent questions before that agenda item arrives. So Becky, if I may ask you to flick through. Thank you. Ensuring we have a responsive system that's able to predict and respond to rising pressures will be critical, and even more critical this winter. So we have purchased a tool, which is called Shrewd, the Single Health Resilience and Early Warning Database, which allows us, Becky, if you don't mind just flicking to the next slide. Thank you. Which allows us to work with all our providers to identify measures which our providers feel are key intrinsic factors that influence and identify pressure in our system, as well as where we may have capacity constraints. These measures are all fed into the Shrewd tool. We are then able to look at individual providers as well as total system impact of where those measures are. And at any point of time in the day, we can identify what our operational pressure escalation level is, better known as our OPAL level, with OPAL level 4 clearly being the extreme black level system. Before, when I spoke to HOSC last year, we only were ever in a position at one point of time in the day to understand the pressure our system was under. We now have a position whereby, as I say, it changes some of our measures. We are now able to change and reflect on an hourly basis. Others still are just daily. But as I'm sure you can appreciate, we are working really hard to ensure as many of the measures that we've got in Shrewd are sensitive and reflective on an hour by hour basis. So one, as I say, we are able to predict, but also that we are able to respond in a timely way. Thank you, Becky. So the plan has been developed. It has gone to our A&E delivery board as a first draft. We are aiming to get the final draft agreed by the end of September, by which time it will be submitted to NHS England and other bodies for review and sign off. Obviously, on top of that, we will need to do a number of winter stress testing, as well as clearly the additional planning we always put in place for those critical weeks such as Christmas and New Year. So that is very much the planning that's been taking place. I go back to, we are planning in a sort of an arena of significant unpredictability, but I believe very, very strongly that we have a strong sustainability plan for this winter that is based on multiple scenarios that could emerge over the next few weeks, months and into the winter. So I'll close there, and if there are any questions, I'm very happy to take them.
you, Maria. That's a very full report. I've got a question coming, I think, from Steve Lydon first. But before I go to Steve, I think it's clear that the discussion we had earlier with Martin about the current COVID issues, that some of those may well be relevant to be taken now, because obviously they feed into what our plan should be. So in the light of that, you may want to. The other point I just wanted to make is I cannot see people with their hands up, which suggests either I can't see them, that's a message for Joe, or that currently nobody's got any questions, which I can't really believe. So we'll go to Steve Blyden first.
Okay, yeah, I think, Brian, the problem is when people are displaying documents, you can't raise your hand on using the system.
Okay.
Yeah, mine are going right back to the beginning. I mean, one is this issue about using 111. I think one of our colleagues from the Forest raised this. I've had this raised with me by some of our elderly residents, and also people who've got like adult special needs, that if you ask a lot of those people, those clients, how are they, and I include my mum in this, on the phone, they'll say, perfectly well, thank you very much. And it isn't until they actually get to see a doctor and actually see somebody face to face, who then looks at them, takes their pulse or listens to their heart, they realise they have got problems. So I just wonder how you're going to cope with that. I've got another two, but these are quite quick. Planning for other potentiality, including impacts of Brexit. I don't expect you to answer that today, but I think I'd very much welcome a written answer to that. What does that actually mean? And the other one, it's an old one for me, and I don't know if we'll be able to cover it elsewhere, but the whole issue of vaccinations and how we can increase the levels. And we touched on this last week at one of the COVID meetings, that I think even one of the trusts, when they really pushed flu, only got 80%, the flu jab, only got 80% coverage. And I think there's a big concern for many of us that we really need to major on the whole vaccinations. And if and when we get a COVID one, we need to ensure that we maximise the taker. If it was up to me, I'd make it a legal obligation. But of course, I'm not Prime Minister. But I'd welcome people's views on that. I'm sorry, perhaps some of these things will be covered later, but I thought now was the appropriate time to take them. Thank you, Chair.
I'm happy to take a few of those. I think I can see Margaret's hand up. Margaret, did you want to come in first?
Not necessarily first, but I just wanted to reassure you that we are doing a massive programme of vaccinating care home staff. And ideally, we're going to the homes as opposed to expecting them to, because we know that they won't go to the supermarket or the GP or anywhere else with their vouchers. So we're looking at spending some of the infection control grant, about £400,000 actually, on going out to the homes 2 or 3 times to try and get everybody on the shift. So that's the plan.
I'll take the NHS 111 question. I guess just to reassure you, obviously, when somebody first rings NHS 111, they are dealt with by a health advisor, a non-clinician. But one of the key elements of Think 111 is if there is any doubt about the sort of support and care that that particular individual needs, i.e. if it is indicating that the patient might need our emergency department or a 999 service, without putting any unnecessary delay into our system, these patients are going to be diverted immediately through to some very experienced clinicians within our Gloucestershire system. These are likely to be GPs and advanced nurse practitioners who will be very, very skilled at undertaking telephone assessment and identifying very early on where patients would benefit from that genuine face-to-face assessment. So I can put that level of assurance in around 111. 111. On top of the flu vaccination question, obviously we are doing a huge amount around flu vaccinations and communication, both to the sort of general public as well as our major staff groups. So I have no concerns or fears the flu vaccination programme won't be successfully delivered across our system this year. I'm not sure I am best placed to comment on Brexit, particularly, other than say, obviously, we are continuing to do a lot of work as part of the PPE and supplies cell group in ensuring that we have a robust and effective supply of PPE throughout the winter period.
Quickly come back, Chair. One of our, particularly, I think it was Terry that raised it from the forest, is that people are almost finding it impossible to get a face-to-face appointment with a GP. And they are getting rung, etc. But it's a fear that many of us have got. Unless they're actually seen, they will say they're okay. And I don't want to labour that point, but I mean, certainly that's a general view that it's almost physically impossible now to get to see your GP. And I just worry that the phone and the video stuff won't cope with that. But hopefully you'll take all that into account.
Can I bring Andrew Seymour in on that?
Thanks, Chair. Thanks, Steve. Yeah, I mean, I have heard that comment before, and I've asked for evidence of this because it's not the experience I'm aware of. But most practices are seeing lots of patients. They're not seeing as many as they were because they're dealing with a lot of telephone consultations, but a lot of those telephone consultations are then translating into face-to-face appointments. So maybe we need to take this outside of the meeting to find out which particular practices you have concerns over. Thanks.
Okay, thank you. I've got 4 people indicating for questions, so I'll come to you in a minute. But just for the benefit of people watching, Mary Hutton has confirmed that they'd be happy to send a flu vaccination briefing through to HOSC for the future, as they have an extensive plan. And Paul Roberts is saying that the staff flu vaccination rates in Gloucestershire providers was some of the highest in the region, highly compared to national comparators too. We will push to do better for you, obviously. So there is some feedback there. But next point, I'm going to go to Dilith, who was the next one to put a hand up.
Yes, actually, I was going to say something very similar to Stephen. Having worked as a GP myself, I can imagine how difficult it is working on 111 because the quality of the information you get from the patient depends very much on the character of the patient. So I have had experience of people ringing up very apologetically, not at all sure whether they needed a doctor or not. And in those days when we went and did our own home visits, I've on more than one occasion, 2 or 3 occasions, found somebody's staff very apologetically polite. Patient was horrified. Whereas on the other hand, some patients with something that's very minor. So I'm just wondering, obviously the out-of-hours system and the 111 system has been going for a long time, so there must be some sort of quality control with that. But more and more people are having to use virtual methods of communication now, and it would be interesting to know whether the lack of face-to-face consultation had caused a significant number of problems. So that is just more of a comment. It's very much on the line of what Stephen said. And then the other thing is I agree with him about vaccines. Spoken to residents.
Sorry, Dilith, we're getting a lot of feedback. Can you just check that your device is not near anything else? There we go.
Is that better?
Yes, thank you.
I don't know what it was, but I'll switch off my phone, shall I? Yeah. The other thing is, I've spoken to some perfectly reasonable people who discussing the possibility of a COVID vaccine, who are convinced that it won't be safe, and so they're not, they're already saying I'm not going to have it. So I think there's a lot of sort of education and encouragement that needs to be given in advance. Even if we don't think we're going to get a vaccination for a while, we should already be encouraging people to look towards that as something very important.
Thank you. who wants to pick up the answer to that?
Brian, can I pick up that, please?
Okay,
we recognise that this is a very new way of working for patients and the public. And indeed, Becky Parish is coordinating some work to do some engagement with patients over the next number of months, because we need to understand where there are issues that patients need support with. We need to understand where we need to tweak and change our services, because we recognise that the COVID reality will be with us for at least the next 6 months. So that's something that we will be working together with other colleagues around the region, in fact, on understanding how patients are reacting. And all of our clinicians are very alive to this, and we'll be able to share some of those results with you. We recognise that we have to do what we have to do at the moment, but some people are actually really valuing the opportunity to have that online access, as well as recognising we have to deal with the difficulties some people will experience.
Thank you, Mary. Can I just come back quickly on that? Clearly, for some people, dealing with 111 or dealing over the phone rather than actually visiting a surgery is problematic. Is there a role for the community? I mean, the community put a big response in to help their local community during the early days of the pandemic. I just wondered if there was a role that the community could play to support the 111 or online surgery approach that we're missing.
I'm happy to take that, and I'm sure Paul may want to come in at some point. We're very much, as we're thinking about Think 111, we're working very, very closely with our community partners, certainly building on some of the excellent work that the minor injury and illness units have started around giving support and telephone advice to patients in our Gloucestershire system, as well as looking at how we better connect with our community services. So can we get sort of direct booking and access into our rapid response services? So it will absolutely be system-wide around how 111 connects and links into all our sort of excellent service provision across the.
I'm sorry, you've frozen for a minute, Maria.
Come back, Maria.
Sorry, I think you lost me. Am I back?
When did you all April? In the meantime, we go to. We're not right with us at the moment.
Hello, sorry, my computer.
Forward to. Are you back?
Yes, I'm back. I apologise. Sorry, my computer seems to have a bit of a failing. So yes, I guess what I'm trying to say is I can absolutely categorically assure you that the 111 service will be very much linking in with all our essential services across the system, including our community partners.
Okay. Thank you for that. I'm going to go to Martin now to raise some questions.
Thanks very much, Chair. I actually had one question arising out of Maria's specific presentation as well, which was, and just to say thank you, Maria, it was a very impressive presentation, and it's clear a huge amount of thought has gone into how to build a bit of resilience into the system this winter. But as ever, some of it is based on sort of admission avoidance. And I'm just a little bit worried that on the back of a summer and indeed a spring, when we had a massive drop in sort of referrals for other conditions, and according to the other papers we've got in front of us today, those numbers still haven't recovered. So not only are there presumably some admissions that should be happening not happening, but we've still got the backlog from earlier in the year. If we now enter into a winter where we're also consciously trying to discourage people from coming to hospital unnecessarily, we may be storing up a pretty major health crisis quite separate from COVID, well, not separate from COVID, caused by the repercussions of COVID, and that things like cancer referrals are going to be storing up really serious problems going forwards. There's no easy answer to this, I understand, but I just wondered if anyone from the Trust had a thought on that. Maybe I should ask for an answer to that before I go back to my other COVID questions.
Could I just comment on that first? We have a communication campaign out to ask people to continue to access services, and we're trying to build confidence in services. So we are asking people to come forward. The admission avoidance issue is not about asking people to hold on to their conditions. It's about dealing with people in a different way. So, for example, we have about 60 plus people, GPs, sent into hospital each day. We're asking the GPs to think about ringing the hospital consultants, first of all, getting advice, sending photographs if necessary, and then dealing with that in a different way. So it's not about taking demand out of the system, it's dealing with demand in a different way. That's what I think our admission avoidance is about.
Great, thank you. And
okay,
actually, I very much like what I heard about the 111 being diverted to GPs and nurse practitioners, because I think one of the earlier problems with 111 seemed to be that when you got to people who just had a checklist, it's not that they were doing the checklist badly, it's that they were very risk averse, so they ended up referring people in unnecessarily. Okay, just onto my broader COVID questions then, and I guess these are probably more aimed at Sarah Scott, our Director of Public Health, than anyone else. As I said in my just remarks right at the beginning, I have quite strong anecdotal evidence from my school-age children's friends that there is, I mean, they've, amongst their friendship groups and teams and classes, they have suddenly got, the Snapchat groups are full of multiple positive test results. And it's clear that perhaps in line with the national picture, we're getting a real uptick of cases amongst younger people. And perhaps this rise in cases, but no rise in deaths nationally, suggests that's right. I was just going to ask, Sarah, if in the case of these cases that are now popping up all in Gloucestershire or in Cheltenham, certainly, whether you have any hold on what is causing them. In other words, are these people coming back from holiday? Do we think they're people coming, is it being spread, through teachers or within schools? And the corollary to that, I suppose, is to pick up on the earlier questions we've had in previous HOSCs about whether or not you, as the local public health team, are getting adequate data from national level that enables you to track and trace these cases particularly. And then the second question is what your expectation is of how this is going to pan out. Are we expecting these cases amongst young people a couple of weeks down the line to translate into lots of cases amongst older people, and then again another situation where we're seeing increased deaths in Gloucestershire? And then finally, just about what your view of the possible response is. And I know, we will get guidance in due course, I'm sure, from government, but not all of us are entirely confident in this government's ability to respond to the crisis. So I just wonder whether you, as the local Director of Public Health, have any specific thoughts on how you think schools and communities, perhaps councils, should be responding to this surge.
Okay, thank you. Just before we go to Sarah, can I, Deborah, I think you did want to come in just now. Deborah Lee, did you relate to this or something else?
I was going to respond in more detail to the point that Mary addressed, but I think we've moved on. So let's continue with the current theme. It feels relevant.
Okay, and I think then, Andy, are you coming in to respond to that? No? Do we have Sarah there, and is she able to respond?
I can respond. Thank you, Chair.
Thank you, Sarah.
Okay, there was quite a number of questions there, so I'll take them all in turn. So you're absolutely right. We are seeing an increase in cases in line with national trends, although thankfully Gloucestershire's prevalence is still low. So we are seeing a week-on-week increase in the number of cases, and our analysis of the data shows that the main increase is amongst those aged around 18 to 35. The schools have gone back, so inevitably school children are mixing more. We knew we would see more cases or more suspected cases this last week. So we are particularly busy at the moment. In terms of what's causing it, and this sort of slightly relates to a second question about data. So we do get access to some test and trace data. We don't have access to the full database at the moment, but that's in train. We will have access to that soon. We work very closely with our South West Public Health England Centre, and I think our relationship across the South West is unusual in that it's particularly strong, and we have a very strong partnership approach. So every week we do a deep dive into the cases we've had, looking for possible outbreaks we might have missed, themes, whether different ethnic groups being adversely affected, different age groups, different parts of the county. The usual epidemiological links are researched in some detail. So a couple of weeks ago, we were seeing a lot of travel-related cases, not so much in the last week, which sort of fits with the last week of the summer holidays. We haven't had, thankfully, a large outbreak, for example, like they've had in Swindon. We've had a number of quite small outbreaks. We've had quite a lot of household clusters, but sometimes just community transmission where we never actually identify how these people caught COVID. And that, in a way, is much harder to control. So, for example, in Swindon, they had a big outbreak associated with an employer. You can focus your attention, your preventative system-wide approach on that employer. And they did so very effectively in Swindon. In Gloucestershire, with sustained community transmission, that's slightly more difficult. So I think what we're also doing there is something around communications, trying to nuance our communications so they meet different parts of the community. So we've carried on with our standard messaging around, hands, face, space, test and trace. So making sure you've got your face coverings, you are washing your hands frequently, you are keeping and observing the 2-metre distance rule, and that if you have symptoms, you are getting tested. And if you are confirmed as positive, you're then working with the contact tracing system. We've designed some messages for younger people. So we're now advertising or promoting things on things like Snapchat, TikTok, Instagram, recognising that not all 20-year-olds are going to be listening to BBC Radio Gloucestershire in the morning, or perhaps I'm doing a piece on breakfast radio, but trying to find different groups. So, for example, the grandparents or the parents might be listening to Radio Gloucestershire. It's about how we get the message out. In relation to adequate test and trace data, I think I've answered that question. It is significantly better than it was, and we are now in a bit of a rhythm of producing weekly system intelligence reports. So one is produced for public consumption, and that went to Adult Social Care Scrutiny last week. And I think we did agree at that meeting we will be sharing all the COVID-related papers with the HOSC members, so that can come out. The public version of this dashboard appears on our website every week, and we have a social media posting every day with a number of cases and changes in that respect. In terms of, the next question was around my expectation around how this might change through the local population. Well, I think we're seeing a pattern where we're seeing more cases in younger people, and thankfully that's not resulting in admission to hospital, and we are seeing very, very few deaths. We might see one a week, sometimes another week, which is a much better position than what we were in the peak in April. I think this is a pattern that's seen nationally, and in some of the high prevalence areas, particularly in the northwest, where they've seen intergenerational transmission, it's because we have quite in that part of the country, sometimes you were seeing multiple generations living in one home, particularly amongst the Southern Asian community. Now, it depends very much, I think, on if people have got it, how well they stick to the guidance, how well are you going to self-isolate, are you going to adhere to the guidance given. I think that's part of our work to try and continue to promote that. I've been talking with the Local Enterprise Partnership this morning around how we can enlist them to try and help us have a much more robust discussion with businesses. We're starting to see workplace outbreaks, so we want to ensure that we're encouraging responsible use of the testing resource we've got. We're still doing around 5,500 to 6,000 Pillar 2 tests each week in Gloucestershire, but we are seeing nationally around 20 to 25% of those people that go for tests don't have symptoms. We're hearing anecdotally that employers are asking staff to go and get a test before they come back to work, or if you've been on holiday, go and get a test to make sure you're COVID-free before you come back to the workplace. That is unnecessary, and it's using testing capacity that needs to be kept in for those with symptoms to try and limit the transmission. The next bit was, how should schools and communities be responding? I think the messages have got a lot more straightforward. I think now we're in this rule of 6. It's quite clear how many people you should be spending time with. I think we're asking schools and communities to try and adhere to the guidance. We've given a lot of information to schools. I'm aware of some schools who have had a confirmed case taking action that perhaps at first glance doesn't look like it's in the guidance. So, for example, if you've got a confirmed case in a class, then that class should go home and self-isolate for 14 days. If anyone in that class, including the teaching staff, then develop symptoms, then they should request a test. Now, I think what is happening, particularly that's quite straightforward in primary schools where they can maintain their COVID bubbles. In secondary schools and colleges, that's much more difficult when perhaps students are moving from class to class. So we have heard of one school that's actually sent an entire year group home. and we're just trying to work with that school now to understand if that was the right course of action. But we are in frequent contact with our schools, but I recognise they're probably inundated with information at the moment. I think the last bit around schools and communities as well is this bit about responsible testing. The issue with Pillar 2 testing has been widely reported in the press. Pillar 2, if you remember, Pillar 1 is the NHS testing route, operated out of Gloucestershire Health and Care at Brockworth, and we've had some brilliant support locally to support the system through that particular testing route. Pillar 2 is the Department of Health and Social Care Commission testing, and you can access that either via the Regional Testing Centre at Hempstead Meadows or the mobile testing units that move around the county. And as I said, we are seeing a number of people either turning up without a test, and turning up without an appointment, or not having had booked a test, and they are being turned away, and we're turning away hundreds of cars a day at the moment. Or booking a test where you haven't got symptoms. So really, we're trying to push that use of responsible testing. And also, if you can't get a test, please don't ring 111, because that's having an adverse impact on 111 at the moment. And we're certainly pushing out some comms yesterday and today to try and encourage people to use the right routes. But I do really understand the frustration that people are feeling in terms of not being able to get a test. I think that answers all your questions.
I think Tim was also indicated. Did you want to add any points there, Tim?
Can I just come back briefly? But okay.
Yeah, certainly.
Sure.
Martin.
Does Tim want to come back first?
Yeah, sure. Thank you. Yeah, well, Sarah has done a brilliant job as usual in replying. So covered most of the points. I'd just like to pick up a couple of things. I mean, first of all, on the comms side, we had a very good presentation last week at the Local Engagement Board from Adam, our comms officer, about what they're doing to target young people using social media. We mentioned there's some quite imaginative and some quite hard-hitting things, sort of don't kill your granny messages. And I think we did agree, Sarah, that information will be given, that those templates of what we are doing will be made available to members. So I'll check that happens. The other point is, I mean, quite clearly, I see on a daily basis what the team's doing, how they're responding. Sarah's mentioned, an education establishment that is very local to me and to Martin, where we're working with them with a particular case at the moment. I've seen a number of emails this morning and meetings specifically taking place today on that to work with the school. So that's some reassurance that we are responding, and I'm happy to go back to Martin.
Thanks, Tim. We'll go back to Martin.
Yeah, and I'd say that's actually very reassuring that you're so on top of it. You identified exactly the case, and the school hasn't only sent the whole year group home, they've sent the whole bus cohort home that the child in question was using as well. But there are other cases in that age group, so sub 18, I think. But that was a very full response. Thank you. I realised there was just one other question I did want to ask about this. There's been quite a lot about people who test positive, aren't admitted, but then have long-term health consequences, the so-called long COVID cases, some of them pretty serious. And I just want, this is a question really to the Trust, I guess, is whether or not we are running clinics or planning clinics for people not just who have been admitted, but who have tested positive and may have other sort of long-term health implications. Because some of them are pretty nasty by the sound of it.
I'm happy to respond to that if it's helpful. I'm sure Mark Pietroni, as my clinical lead, may add, but Martin, it is a really important point. I think we're only just starting to understand the impact of long COVID. We have led the way in establishing multidisciplinary clinics for patients following COVID. They involve up to 8 different professional groups: psychologists, pharmacists, respiratory physicians, exercise specialists and the like. At the moment, we have prioritised that against what we're judging to be clinical need, which are the patients that were initially admitted to hospital, and particularly those that were most unwell. But as you've identified, they aren't the only cohort that have been affected. So the next stage is to look at whether we establish this on a referral basis. So these patients will typically present to primary care, to their GP, be triaged, as Andy's described, by telephone, and then possibly a face-to-face consultation. Our ability to continue that beyond the end of September is linked to the funding regime that we're expecting to be announced this week. So some really good work, really, really valued by the patients that have attended, especially not least because we invite their family members as well as the patient, as you've alluded to, at its severest form. This can affect whole families, not just individuals. So yes, it's in hand, but for a limited cohort, and we hope to expand, but that is subject to the national funding regime enabling us to do that.
Thank you, Deborah.
The only thing I would add,
Mark,
Chair, if I may, it's Mark
Yes.
Petroni, I'm the medical director of the Trust, is that
Yes, certainly,
obviously
Mark.
recognition is really important, and it's easy to recognise people who are admitted. So one of the things that we are doing is sharing information with primary care, particularly around how to recognise symptoms of what is coming to be called long COVID in common language. Just so that we can link up. And I think one of the things we did really well during the earlier months was work across the Trust and primary care. And we're continuing that through both formal and informal mechanisms. Because if GPs can recognise patients who have long-term symptoms of COVID, then of course they can, that's the first point to accessing services. So that's just another point of assurance to the committee chair.
Thank you, Mark. Martin, you comfortable you've had answers to your questions there? I'll take that. I think that is a positive. So we're going to move on then to
sorry, I was just going to say yes. If some trusts are doing it, we need to question this thing about the funding formula, but that's something we should take up with government, I guess, because some trusts are doing clinics for people who haven't been admitted, even though they're under the same funding formula as us, presumably.
We're under the same formula until the end of September. For us, the constraint is availability of workforce to do more than the number of clinics we're doing. I've described, Martin, quite a complex model involving a whole raft of professionals. We've also delivered these in community settings, so there has been a constraint. There's been a national dialogue about this, and I haven't yet come across a trust that is doing more or better than we are in this space. Indeed, we've had a number of people come to visit our service because it has been upheld as exemplar. So yes, I would love to be doing more and to be able to see more patients. But I think our approach to prioritisation, noting that we will always manage an individual by exception. So if Andy or a colleague were to pick us up and say, I have a patient in great need who didn't hit your hospital, then we would always seek to accommodate them on that basis.
That sounds excellent.
Can I just make a final comment before we move off this the topic of testing that Martin raised? And it is just a small point, but much of the narrative in today's media has been about how the government is not yet prioritising who does access testing. So I just wanted to add again, in Gloucestershire, because of the model that we established early on, which is not only to have access to what Sarah described as this Pillar 2 capacity, which is what all the national media is about, that serves the public at large, is we do have dedicated what's known as Pillar 1 testing, which means that for us, healthcare workers in particular, but other key workers, can access testing through local services delivered by the NHS, through our partners in Gloucestershire Health and Care, using our local laboratory, not relying upon the lighthouse laboratories. So we don't have staff sat at home who could work for want of a test result. So that isn't at play in Gloucestershire, which again I hope you'll see as very positive.
Thank you, Deborah. That's very, very good to hear. Right, I'm now going to move on then to Paul Hodgkinson, who's got a question, I believe. Can I just add as well? If you've asked a question, can you take your hand down? So, because otherwise it looks like everybody's got their hand up. Thanks.
Okay. Yeah, thank you. I've got two questions actually. One just is going back to the flu vaccination point. I know we're going to get a paper on that. That's great. For me, it's about and people have raised this to me, it's about the lack of clarity about who's eligible and who isn't. So there was a big thing during the summer by the government saying everyone over 50 would benefit from the flu vaccine. So that would mean me as well. So I was very happy about that, only then to be told when I asked about it that no, you won't get it. You're not the priority. The priority is the vulnerable, particularly over the age of sort of 65, 70. So I accept that point, but it's very unclear. And I'm also getting personally targeted messages on social media from people like Boots telling me to get a flu jab and how they happily offer it to me. So can I just have some clarity on that, please? That's the first point. Second point, it relates obviously to winter planning. And the presenter. So I've completely lost where that person. There we are, Maria. Yeah, I can see on screen now. Maria, you mentioned about when a possible second peak happens. Well, obviously, the number of infections is rising a lot. So we may well be on the edge of that second peak. We hope not, but we may be. And one of my concerns is what happened with the critical incident that was declared at Gloucestershire Royal recently, and how that then translates into how that hospital is going to cope when we're really up against it in the winter, because obviously that incident happened during the summer. So my questions around that, and it may be that we can take these later as well, I don't know, is what happened? Why did that happen? Why did that critical incident happen? You know, how bad was it? How long did it take, you know, to recover from that? And is it still recovering from that? And what does it mean then for winter preparation when the service wasn't coping in August? So, you know, some fundamental stuff there that I think the public need reassurances around, please.
I'm happy to sort of take part of that question. Obviously, we took a whole system response to an incident that was declared as an internal critical incident by the acute trust. So I'm sure Deborah will want to come in and talk to this. But I suppose from a system point of view, I do want to assure you completely that we took full responsibility as a system to review those what led up to the events and subsequently happened during that event, and have taken some significant learning from it that we have applied into our winter planning. But I'll hand over to Deborah, who will give a much more specific answer, I'm sure.
Thank you, and I have got colleagues in this meeting who are actually at the fore of that, so I think probably 3 points to make, if I may. So firstly is to note that despite, and I recognise the language may feel alarmist, and certainly I think there was some alarm in the way that it was reported and presented, but just to reassure and provide assurance that this is our response to situations where a number of things can be at play, including enhanced demand. So, for example, if we were to experience a flood or we had issues with our generator, then we would call this form of incident. And the reason we do that is because it gives us the very best response in the shortest of time. It provides absolute clarity to the workforce about their priorities and what's expected of them. And experience tells us that when we responsibly declare this sort of incident, then we're much more likely to effect a reset and get back to where we want to be as quickly as possible. The second point to note in relation to demand is to observe that we were coming back out of our pandemic demand levels, and we were planning at that period of time for demand to be at about 80% of previous levels, and that was what we were basing our planning on. That was entirely reasonable. It reflected other systems. It's very much what we were seeing. We then had a heat wave, and what we see from previous times is that during a heat wave, demand goes up by around 20%. And we are always prepared for those eventualities, especially as you might expect in the summer. But because of some of the challenges of the way we're delivering services now, from PPE to social distancing, that did cause us some additional challenge. And then the final point, just to note again, it is on the demand point, is that we had an unusual August in that we had this model of both staycation, where people weren't leaving the county in the volumes they often do, and we also had the issue of quite a number of incomers who weren't going abroad, coming to the lovely Cotswolds and other parts of Gloucestershire to holiday. So we can see from data that came out of the Tourist Board that we did have high levels of patients and population in the county. So as ever, there were a number of issues. Do we expect it to reoccur? Well, we can see that in winter we typically have to rely upon this incident response and structure on, I think it was, Rachel will correct me, but I think 4 occasions in the last planning period. So it's not unprecedented, but it does serve as well. But again, the focus of this morning's winter plan is to make the likelihood for the necessity of that manifesting as low as we possibly can through all of the actions and mitigations that we've described.
All the stuff that was answered there, thank you. The point about flu vaccinations wasn't there, was it?
Chair, can I comment on that?
Thank you.
Please.
I think Deborah might want to.
There's a comment from me in the chat call as well, if you want to see it.
Yeah, Deborah's commented on what I would have said anyway, but the guidance is very clear, and I think we acknowledge the communication could be better, but the higher priority group are the same group as who would normally vaccinate year on year, and we need to get those done first. And then the additional group, the 50 to 64, will be done in due course. So they will. You are definitely eligible for vaccination, but we need to do the higher priority group first.
The guidance, Paul, suggests that from November, those in the younger age group will be done, and that's very much the model that we're building upon. I hope we might get there even sooner.
Okay, and can I just ask a point on that? Will people in that age group be contacted proactively, or do they have to take the initiative themselves?
As far as I understand, that we are still waiting for national guidance about how it's going to be delivered, whether it's through primary care or through other vehicles, and when that's decided, the communication will follow with that.
But my understanding is, Andy, I think you're in the same place. It won't be a personal invite to the 50 to 64 group, but it will be widely promoted as an offer available.
Thank you. I think that's quite clear. Okay, we'll move on then to Stephen Hurst, who's got a question.
I think my question's already been answered. It was around the priorities that are identified through any modelling which may take place. Numbers. Thank you.
Yeah. Thank you, Stephen. We'll move on then to Terry Hale, who's up the question.
Yeah, thank you, Chair. Just like to reassure that Stephen, we was talking about the Forest of Dean and how difficult it was to actually get an appointment to see a doctor, let alone see a face-to-face. My surgery, and I sit on the PPP, the panel, we was closed. We didn't enter the surgery for, I think it was 10-12 weeks. We was made to queue outside. We was actually, I've had numerous people ring me up, elderly people from out of my area that was absolutely isolated, couldn't get to the doctor. Then all of a sudden we had if you rung up, you had to fill a questionnaire that they looked at before they actually phoned you up. And now, this is not really what we want for our elderly people. The stress that caused, as I said, the people that rang me up was, they were stressed, so stressed it was terrible. But I will. Becky's going to have a word with me after, and just reassure Stephen that if there's anything happening in your area, get in touch with Becky. I think that would be the best thing, and see if we can sort something out. Thank you, Chair.
Thank you, Terry. Did Andy Seymour, did you want to come back on that at all? Or,
Well, absolutely. As I say, I'm disappointed to hear that, and we need to look at it from a particular practice and any that Steve has as well. I would hope that is certainly not the case now. I think in the early days of COVID, there was a lot of confusion about the right way to handle access to primary care. But I think that it's very clear now that practices should and are expected to be open and seeing patients on a face-to-face basis.
Thank you. Right, I don't have anybody else indicating to speak. That all the plans that are up, I think, have already spoken. So if that's the case and nobody shouts now, I'm going to close this particular item now and thank everybody for bringing forward the winter plan. And clearly we've understood, I think, some of the challenges this winter and how there's a lot of uncertainties that are playing out as we move into it. But at least we've got a clear direction of how things are going to take forward. What I'm going to suggest we have now is a 5-minute comfort break, and then we'll come back in to look at the item 6, the COVID temporary service. So we'll come back to that at 11:25. Okay, thank you.
was just testing that, Brian, to make sure it was working okay.
That's fine. I'm probably going to make a lot of noise.
I'll mute.
No, it's not you. That was me. I've got 2 devices running. I just connected one.
Okay, cool.
Right. I said 25, didn't I?
Just be honest, this is still streaming live on YouTube.
That's fine. I was just testing so that we don't have a gap with the, but thanks for flagging that up.
Yeah, it's a bit more interesting on the full council when we were streaming live, having it in our breaks. But
I'm very grateful you just flagged up that Brian. I hadn't appreciated that.
Yeah. Right. Yeah. Oh, no, it's just the YouTube runs continuously. So although you can't necessarily see anything, you can certainly hear everything people say. Which, as it would be in a meeting.
Mm.
Okay, back at 11:25. So I think we will get the meeting underway. So we're now moving on to the this is the next item is looking at, we've got Ellen Rule, who's going to be presenting the temporary service changes. So over to you, Ellen.
Thanks, Brian. So just to say, I also may invite my colleagues to join in. So the paper you received was a triple effort between myself, Simon Lansley and Angela Potter, who are on the call today. And the paper constituted an overview of the issues, the proposals around the temporary service changes, and then appended some of the MOU proformas that we used to notify and provide additional detail on the temporary service changes that are actually proposed. So you have 2 that are brought forward from Gloucestershire Hospitals Trust and 2 that are brought forward from Gloucestershire Health and Care. So my suggestion, Chair, is that I provide an overview of which I'm going to do via this PowerPoint presentation. And then if you're happy, I pause there and we take some questions. And then if there's any more detail that we want around the contents of the 4 proformas, then I'll bring in Simon and Angela to help deal with some of those questions or issues, if that sounds okay. So some members will have had some of the contents of the presentation previously at the briefing session, and I know not everybody was at that, so some people could perhaps forgive me for repeating some of what I'm going to say, but I think it's important and also provides an opportunity for those listening via the YouTube broadcast to hopefully receive a very condensed overview of the issues in hand that are contained in what's quite a long and complex paper. So we're going to provide an overview of the temporary service changes proposed to support our response to COVID-19 and the ongoing recovery. And I will also describe how these link across to the winter plan for this year, which you've already heard the presentation on from Maria. I will pick up a couple of issues that are not in the paper just at the end, and just share with the committee and people who are listening an update on a couple of items that were due to be in this meeting but have now been deferred to October, because I know these items are of interest, and that is about the Fit for the Future programme and the Forest of Dean review. So starting with the temporary service changes update, we've heard and discussed already how the COVID pandemic has had a significant impact on health and care services. I just wanted to stress a couple of points. Although active disease levels remain fortunately low, albeit in the context that we've discussed already in this meeting, we do continue to feel a really significant impact on the productivity of health and care services. And that's for a number of reasons. So care providers in all settings, and I'm talking about the hospital and community settings, have to, of course, ensure that staff and patients can maintain safe social distancing and carry out additional infection prevention and control measures. That includes things like extra cleaning, extra hand sanitising and washing, extra PPE and so on. There are many measures that are contained within that. More of our care delivery continues to be delivered remotely and online because that's, we know, is a safe and effective method, albeit again with some of the caveats that we've discussed already earlier in this meeting. And what that means is that our face-to-face care services for both planned and emergency care in hospital and community are operating at roughly about 80% of former capacity. And it's important to stress this does vary quite significantly by service line. And over the next few months, some of those will recover to more like normal levels. But if we take a broad look at where we currently stand, it's approximately about 80%. Again, as we've also discussed, the threat of the peak of infections is not over. And we are maintaining a readiness to respond to any future virus waves or peaks. And so the winter plan you've heard about already wasn't based in the same planning assumptions of plans we've written before, and the temporary service changes are part of that picture. So moving on to the next slide, if it will let me click through. So again, as Maria discussed, we worked on a range of winter scenarios, some of which did have and some of which didn't have a second peak of COVID. But it's important to stress that all the scenarios had to assume that the productivity challenge I've described will remain. And this is at least until a safe and sustainable vaccine is found and rolled out at scale. So in some services, this means we're around 80%, although I said that is rising in a number of areas, but where we could experience up to about 100% of usual demand. Because again, the point was made by Martin that we are seeing some of that demand pick back up again. Absolutely we are, and we recognise that. And so the temporary service changes are really talking to these issues. So we want to achieve the following aims by introducing them. We want to limit the risk of transmission, in particular by limiting the routes by which emergency patients can enter the hospitals. We want to continue to enable the resumption of services paused or reduced during phase one, and this includes planned care, specialist diagnostic activity, and particularly ensuring that patients who are the most vulnerable can maintain their access to treatments even after the surge. And we want to give confidence to our local population that both of our hospitals are safe places to receive treatment. And so what we want to talk to the committee about today is that to manage these ongoing risks presented by the possible second wave in the background context of the impact on productivity, we believe it's the right thing now to maintain temporary changes for the next 6 months, and that this is irrespective of whether we experience a second wave or not, because that means that we'll be able to maintain more planned care, so inpatient operations through the winter months, because we will protect both planned and emergency care, and that any changes that we put in place now to contemplate reversing those in December at the peak of winter pressures does not feel like a sensible proposition, and hence why we're proposing the 6 months. So on to what the temporary changes are, and I know the committee are familiar with some of these from our previous presentations, but there are some changes to this iteration of the proposals. So proposal 1 relates to the continuation of the temporary reconfiguration of emergency general surgery to Gloucester Royal. Proposal 2 concerns the second suite of temporary service changes we implemented, which includes Cheltenham ED operating as an MIU temporarily 7 days a week, and the centralisation of all 999 and undifferentiated GP referrals to GRH. And it should be noted to the committee that this has also resulted in a significant volume of respiratory care moving to Gloucester Royal since June, And that's a combination of the risk management around COVID and the nature of the patients who are arriving with undifferentiated respiratory symptoms. The next point relates to the acute stroke unit, which has actually moved across to Cheltenham, while the hyperacute stroke unit remains at Gloucester. Emergency and elective planned vascular have moved to Gloucester, and in terms of emergency urology pathway, that has also moved to Gloucester, with planned pathways remaining at Cheltenham. So the proposal is that the changes we implemented in phase 1, which is proposal 1, and then in phase 2, which is proposal 2, are now extended using the terms of the emergency change set out in the MOU, are now extended for 6 months, so to March 2021. The next proposals relate to community services, and there is some adjustments to the previous proposals. So as part of, again, those phase 1 changes, at the start of the incident response, a number of our minor injuries units were closed. This was to enable the redeployment of staff and the management of safe environments. We renewed this for a further 3 months in June, and that proposal now is to reopen a number of these MOUs, but with the exception of the DILC, which would remain temporarily closed. It should be noted as well that in terms of opening hours, there are some adjustments compared to our normal in inverted commas, thinking back to pre-March opening hours. So Tewkesbury, the Vale and North Cotswolds minor injuries units will continue to be open from 8 AM to 8 PM, which are the standard normal opening hours for those services. The minor injuries unit at Stroud, Cirencester and Lydney will continue to operate on reduced hours, 8 AM to 8 PM. And I would also, just to be really specific for the committee, share that the Vale minor injuries unit will open in October, initially 10 till 6, but moving to 8 till 8 after that. And that is purely to manage staffing pressures and to do with the reintroduction of staff who were redeployed to other areas back to the minor injuries service. The final change, which is actually a new request to the committee, a new sharing of a temporary change, is the temporary reallocation of 6 general rehabilitation beds at the Vale to provide additional capacity for stroke rehabilitation to support flow through acute hospital stroke units. And actually, there is a secondary aim, which is ensuring a safe and COVID secure environment for patients who are quite vulnerable at the point when they're receiving stroke rehabilitation within the Vale setting. So, as previously noted in the presentation, to manage the ongoing risks presented by the second wave and the ongoing impact of productivity, we want to maintain these temporary changes through the winter plan period, so to March 2021. Okay, I'm just going to provide just a couple of slides for, these were not on the agenda today, but I know are of interest, and we had said in the previous public meeting that we would bring these to the September meeting. So I just wanted to share where we were with Fit for the Future in the Forest of Dean. So as committee members will be aware, our Fit for the Future proposals set out our plans around specialist hospital care with the following objectives. So improving health outcomes, reducing waiting times and fewer cancelled operations, ensuring patients can receive the right care in the right time at the right place, a focus on safe staffing levels, put my teeth in, including senior doctors being available 24/7, and attracting and keeping the best staff in Gloucester. As we talked at the beginning, we're actually already seeing evidence of that coming true. As all change proposals, we are subject to the 4 statutory tests for service change, and then the 5th test, which is not a statutory test, but the NHS England bed test. And I know that the committee is interested in ensuring and being cited on the progress of our system against the statutory test, because these tests must be met prior to approval to proceed to any consultation. So I will provide a short update. So test 1 relates to strong public and patient engagement. So our plans are quality assured by the Consultation Institute and have been adapted for a COVID-19 socially distanced consultation. And the view is that we have met this test, and we obviously will bring forward that consultation plan for review by the committee at our next meeting. The next test is consistency with current and prospective need for patient choice. So this is always a balance across the whole piece. So our proposals, which I realise the committee have yet to see in detail, but we'll see soon, have been assessed as follows. So outpatients, which constitutes the bulk of the footfall, is unchanged. Some inpatient care locations change from west to east and from east to west. And we also developed the opportunity to repatriate some out-of-county patients. So what that means is we can offer care in Gloucestershire for some conditions that previously you had to travel for Oxford or Bristol or Birmingham to access. So actually we increase choice by offering a local choice. So when taken in the round, we have met this test. The next point is test 3. Is there a clear clinical evidence base? And we have an independent reviewer, which is the South West Clinical Senate panel, and they have supported the clinical case presented, and that report will also be brought forward and shared in public so that people can review that. So that test is met. The next test talks about support for your proposals from neighbouring clinical commissioners. And we approach all of the commissioners that operate around our borders, so Oxfordshire, Worcestershire, Warwickshire, Bristol, and I'm in Devon in Wales, etc. And also NHS England specialist commissioning, as a number of our service proposals involve the development of specialist treatment options within Gloucestershire. As I mentioned previously, you had to travel out of area to access. This test is partially met, not because we anticipate any issues with it, but as I'm sure people can imagine, people have been very busy, and this is an administrative ask requiring people to take the necessary through their governance committees and provide us with written support. We are now confirmed to be receiving this from all of these commissioners in the next 2 weeks, and so we expect the test to be met. And then finally, the NHS England beds test. There is no reduction in beds proposed in this case. Effectively, the test does not apply, but in fact, the test is met. So in terms of the review's timeline, in order to work through the remaining few issues, we've extended the timeline a little to ask if we could bring this forward to you in October, to start the consultation in mid-October, and we would then have a public citizens jury in mid-January. And our stage 2, NHS England stage 2, which is the assurance point where we get that formal approval from them as our assurers, is planned for the 1st of October, and we would take it through our own board committees around about the 8th of October. And just to note, with regards to the Forest Dean, that consultation will focus on the services to be provided in the new hospital. And we plan to align the timings to the timeline above, because although these proposals are not linked, the challenge of running an effective socially distant consultation and engaging with those communities and the resources we have available to us in our very small team, Becky's team, means that to try and run 2 things on different timelines is just not practical. So we're going to align those timelines and run them to the same. So I think that's it for my presentation. I will stop screen sharing. I think I pretty much picked up the issues in the paper, although I am very happy to talk through that as well if people would find that helpful. But so just for now, I'll just pause there and hand over to you, Chair.
Thank you, Alan, for that presentation. I've got Steve, I think, was first with his finger on a button to ask a question, so we'll go to Steve Blyden.
Thank you, Chair. Yeah, first of all, I think we discussed it, last week. I think the 6 months extension temporary move is the sensible one. It's far better, I believe, to do that than it is to do ad hoc or a monthly basis. People now at least know where they stand. My general comment, though, is really about understanding the differences. And I know you grasp this, but in my mind, I've got temporary services changes, fit for the future, and winter planning. And I'm just wondering how we could better, maybe we need to talk to the comms people, but how we can strip out, they are all interlinked, but how we can strip out the different facets that apply to each of those. Because otherwise it is, to be fair to us, and I always think about the patient as well, it's very confusing for them. And some of us have to go back to wider groups like committees, etc., to explain these sorts of things after these meetings. And I'm just wondering if that's being thought about. I mean, we have talked about it before, but it would certainly help us, if nothing else, colour coding the various aspects. Anyway, I'll leave you with that thought.
No, I think it's a really helpful thought, Steve, and I think it would be easier, or it will be easier actually, once we've had the final future proposals in the public domain. And we've been working on some kind of infographics, exactly as you said, actually, using some kind of colour coding or a grid. Like, this bit is what we propose for the longer term, this is for the short term. Because I agree, it is complex and the last thing we want to do is make it opaque and confusing for people, because we want them to be able to contribute and help with this process and not feel bamboozled by it. So, yeah, absolutely take your feedback on board. Thank you.
Are you happy with that, Stephen? Right. I don't have anybody else indicating. I do. Dilys is waving at me. So, Dilys, would you like to come in with your question?
Yes.
And me too, Chair.
Thanks.
Okay.
Yeah, I'm sorry. I think I asked a similar question to what I'm going to ask now to the previous meeting, or tangential to it. It's about our preparedness for if and when a vaccine is rolled out. My guess is that if and when we get a vaccine which is deemed to be A, safe, and B, effective, in that order, there will be enormous pressure to get it delivered quickly. So I think I asked before, are we prepared to roll out the vaccine rapidly? And I was answered about that one. But then once that's been done, what ideas are there? What plans are in place as to when temporary changes could begin to be reversed? Is it when all the staff who might encounter patients who are still COVID positive, or when all the staff have been vaccinated, or would you be looking at a certain level of vaccination within the population for the herd immunity to be raised? Because that will sort of indicate how long the temporary changes are going to have to go on, and whether we're going to be looking for a further extension after the next 6 months.
I think Deborah Lee and Andy Seymour both maybe want to respond to that.
I'm happy to respond to it in the context of the changes in my own organisation. I think what's really important to remind ourselves is that we've located these very specifically, Dilys, in our winter plan. So at the moment, our expectation is that we will review the ongoing necessity for those at the end of winter. I think that all of the things that you've talked about will be consideration. So if we go back to the initial objectives that drove the need for these changes, the ones that relate to the pandemic response, which was about reducing the risk of transmission at our front doors, ensuring we could maintain as much of the really important routine work we've heard about this morning, both in terms of cancer surgery, but also the hips, the knees. So what we will need to do at the end of this winter period is to go back and judge our ability to continue to deliver those temporary changes, those objectives, with and without these temporary changes. And again, they are presented as a bundle, but they may not be reversed as a bundle. It may be that some can be reversed and we need to retain others. But again, going back all of the time to those original objectives. We recognise the importance of these changes not being perceived or drifting into a permanent scenario without us doing what we've committed to do, which is full public consultation on any changes that we propose should become permanent. A vaccination programme is an important part of that, but it's not the singular part of that.
Okay, thank you. Andy, did you want to add anything to that?
No, it's all right, thank you.
Okay, thanks. Right, are you happy with that, Phyllis?
Yeah, there's a lot of unknowns, but I'm happy with that. Just thank you very much.
Okay, thank you. And we'll move on to Martin then. You had a question.
Thanks. I've got a couple. The first is just to pick up on Councillor Liddon's point. Although this agenda item is entitled Temporary Service Changes, we are now discussing the timetable for permanent changes. And I just don't think it's good enough to have these things conflated in this way. I think we should consider the temporary changes and the extension, and then we should separately consider permanent, or the consultation on permanent service changes. And I have to say, I would argue that if it's a difficult time to think about restoring services post-COVID, because we are still, as you've quite rightly said, quite possibly in the middle of the epidemic, that we may have fresh surges, we may have fresh pressures on staff, there may be fresh restrictions on movement by members of the public, then I'm afraid that argument to me holds equally good, that you shouldn't start to plan permanent reorganisation in the middle of an epidemic either, because the situation is very confused. The permanent service changes need to accommodate whatever the new normal is, and we don't really know what the new normal will be. And it seems to me to be rushing into this consultation on permanent change in a way that's quite inappropriate in the middle of an epidemic and with a whole load of temporary changes currently in place. Secondly, there was no mention of the emergency and urgent care at the two sites, Cheltenham and Gloucester, but obviously there is a widespread fear in the community that the detailed proposals, if we're now seeing them in October, will include a permanent downgrade of the A&E at Cheltenham General. And so Deborah has very clearly reassured us on this previously, that these are temporary changes and that they envisage a restoration of a Type 1 A&E at Cheltenham General. So I would like the HOSC to ask, and I'm happy to put this in the form of a motion if necessary, for the plan for service restoration of a Type 1 A&E at Cheltenham. We were assured by Deborah at the previous meeting that these current changes were temporary and that this would happen. So I think we'd like to see a plan for that, and I think that would provide significant reassurance to people in Cheltenham. Third question is picking up on something that Councillor Hodgkinson said earlier on, actually, which is this fear that the weak link in all this is Gloucester's A&E. Even post the closure of Cheltenham A&E, temporary closure we hope, we still see the 4-hour wait target being consistently missed by the combined A&E at Gloucester. We've heard about the Black Alert in August, which the Cheltenham Reach campaign tell us lasted 4 days and involved patients being diverted by ambulance from Gloucestershire to Bristol, who wouldn't normally have gone there. Well, I see Deborah shaking her head. She can reassure us that that's not the case. But I'd like to know, and there were anecdotal stories of a queue of ambulances at Gloucester A&E over this weekend. So perhaps you can confirm whether or not there have been any further black alerts since the one on the 10th of August. But this just impression from all the data that we're seeing an A&E department at Gloucester that really can't cope with this kind of pressure for whatever reason. And again, it seems sensible to wait until the current situation and the temporary changes have panned out and what we learn from those before moving on to permanent changes. And then the last question builds on another thing that Councillor Hodgkinson and Mr. Taylor at the very beginning of this meeting pointed out, which is the impact on various localities. The independent travel assessment in our papers already shows this huge negative impact for people in Cheltenham from the proposed service changes to general surgery, with 481 passenger journeys negatively affected. it doesn't show any negative impact at all for the North or South Cotswolds, but that's an interesting geographical split. If it was East and West or something like that, maybe there would be something showing up. But if the risk is of these changes being made without proper impact assessments on the social and other inequalities that exist in our communities, then I would really worry about these negative impacts that are being revealed in the data for Cheltenham and the east of the county. So I just want some reassurance that Mr. Taylor's example of the phlebotomy changes happening without proper impact assessment isn't going to be repeated in this case.
Thank you, Martin. I think we'll go to Deborah Lee and Ellen. Or Ellen first. I don't mind.
I mean, I'm not sure whichever order is fine, but I just thought there's a long list of questions. So I just thought I would start with the first one and then probably hand over to Deborah, because I think the first question was about some questions regarding why I'd presented what I had presented and were we conflating the two. And I just wanted to pick up that. So I think I apologise if I was unclear in my presentation. I think I said at the beginning that I was providing just an update on the agenda items that moved to October. So I wasn't seeking to present in any detail on Fit for the Future or conflating the two, but I do realise it's quite complex and that there is this overlay that Councillor Lydon just referred to. And it will be easier when perhaps we do bring the detail and Fit for the Future in October. So there's certainly no intention to conflate the two. And I think also in the HOSC paper, in section 4 and 5, we stress that the temporary changes have no impact on the commitment already made to Cheltenham Emergency Department. So we have clarified that in the paper you have received, and that the Fit for the Future consultation will not contain a proposal to downgrade Cheltenham permanently to a minor injuries unit. We have been completely clear about that all the way through. And I think Deborah's reiterated that in the comments bar to the right. I think in terms of I hope that covers the points about the potential to conflate the two. We have stressed they are different. They are based on different planning assumptions. One is dealing with a pandemic. One is a longer term proposal around sustainability and the development of services that are innovative and future facing. So I hope that that is clear on that point. I think I would then hand over to Deborah with regards to specific comments about now and the Gloucester A&E department.
Thank you, Ellen. And Martin, just one comment on that, the timing of the approach to Fit for the Future and consultation, because I think what you might have been alluding to were a perception of there being benefit of not commencing this consultation until we were beyond the pandemic. And I understand the reasons for that. So I suppose a couple of points that I would just reflect is, firstly, we're not starting this during a pandemic. We've been at this for a number of years, and there is a lot of frustration and concern being expressed by the public, but also very much by our own staff about the continued uncertainty and anxiety. You've all expressed concerns here previously that we may lose staff or may not recruit staff because our direction of travel is unclear. So I think there's a real case for considering that timing very carefully, and I believe we did that. Obviously, the longer we delay, then the longer we withhold what we perceive to be considerable benefits from this change. That, for me, is another important driver of why we wouldn't want to necessarily pause unless we could evidence that it was appropriate or indeed unlawful to continue. And the other thing I would just note, because I'm not sure how aware everybody is, but one of the things that we've seen in relation to behaviours during lockdown is that, firstly, people had a lot more time on their hands to engage with things that they might not usually engage with. And the digital and virtual platforms enabled a degree of access, particularly in a rural community, that we hitherto struggled to achieve. So, for example, involvement in many of our meetings, involvement of the public at our board meetings, at our Council of Governors, has been better than it's ever been before, and certainly better than it was pre-pandemic. So I wouldn't want us to just rule out effective consultation because we're in pandemics. Actually, I think there may be some benefits. We must be alive to digital poverty and all the things that affect people's ability to engage. But I think, the work that Becky Parish has led with others, supported by national experts, means that we've got an approach to consultation that the Clinical Senate described as one of the best that they had seen, and particularly one that was sensitive to the pandemic conditions and context. My second point then is just to note that we all respond to the information that's in the public domain. So I have no concerns about you repeating what you've heard, but we have reached out to stakeholders in the community to encourage them to work with us in checking the factual accuracy of comments they make and things that they perpetuate over social media platforms. Because if ever we needed to promote public confidence in health services, it's now. We need to promote confidence that people that you described earlier that are sitting on illness, that may have a developing late-stage cancer, don't feel afraid to come to our hospitals. But sadly, we do have a lot of misinformation in the public domain. Sadly, you cited some of that earlier. The incident lasted for 2 days, not 4, and no patients were diverted out of the county to other hospitals as a result of that. So to respond to the other point, which is really relevant and valid, we've discussed it here many times, which is about the capacity of GRH to deal with these temporary changes and indeed to deal with the future. So to pick up the first point, we have increased the physical footprint of GRH by 85%. So it is nearly twice the size that it was, despite only around 20% of Cheltenham's former activity now being directed to Gloucestershire Royal. So 80% of what Cheltenham did, it continues to do and continues to do very well. We've also provided more staff to Gloucestershire Royal to deal with that larger footprint. So I don't deny that it's not a very busy department. I don't deny that we've had ambulances queuing. What I do believe is that without the temporary changes, we'd be facing an even more difficult and challenging situation than we're dealing with now, and that patients' experience would be less positive. And I have to draw us back to why do we have the model that we have, and it's about limiting routes of access to our hospitals as the pandemic evolves and as cases start to rise again. As things stand, we can only test patients at the front door of one of our hospitals, and we do that very quickly, and it makes our pathways very safe. And it leaves us with a very safe hospital in Cheltenham to continue to deliver cancer care and diagnostics and imaging to vulnerable patients. In respect of the longer term, then the challenge around the adequacy of Gloucestershire Royal to manage the services we're proposing should be delivered there for the whole county in the future. And we will deal with that challenge and respond to it during that consultation. It's an absolutely fair challenge. I think we can respond to it. It does mean that all these changes won't be implemented overnight. Some of these changes will be implemented over a period of years, not months, because we need to develop our infrastructure on both of our sites in order to deliver the model that we're talking about. So I hope that's helpful, and happy to allow particularly clinical colleagues to comment if they've got anything else they want to add to that from my own team.
Chair, it's Mark Petroni here again. If I might just add a comment.
Yes, certainly.
With reference to the temporary changes, a number of committee members have commented on the backlog in care. And one way of looking at that is that during the first COVID surge, we did really well in Gloucestershire in looking after our emergency patients with COVID. But those who suffered were those who had chronic long-term conditions or undiagnosed cancers or cancers requiring treatment. And the whole purpose, or part of the purpose of the temporary changes, after keeping patients and staff safe, the second main aim is so that we won't be in that situation again. And none of the clinicians in the trust wish to be in a situation where they cannot provide care safely to people with cancer or with chronic long-term conditions. And the temporary changes, I believe, and I've been around this one many times, and I've since checked it with a number of national experts to make sure that we've got this right, provide us with the best configuration of services to provide both emergency and planned care during the winter and during a COVID surge, which is what we have to plan for. I don't wish to suggest it won't be difficult. It will be difficult. We are continuing to learn, We're all doing this still for the first time, but I do believe that this is the best configuration in order to provide the best care we can to the largest number of people we can, and in a way that is safe, both for our patients but also for our staff. Thank you, Tim.
Thank you. Martin, I think you've had a fairly full answer to your questions there.
There were two.
And in particular, an assurance regarding Cheltenham General Hospital. So that probably leaves you satisfied?
That was very welcome indeed, actually. And thank you both to Mark and Deborah for giving very full replies there. There were just two specific questions I asked which didn't get replies, which one was whether there had been any further black alerts.
No, they have not.
They haven't. Okay, that's good. And thank you for correcting the earlier information if that was wrong. That's always important. And then the other one was just about the impact assessment on the geographical areas where it's, we have got, although Cheltenham has an affluent image, it has some very low income areas, and there are people who struggle to get transport. And in the same way that the independent travel assessment reveals inequalities, it would be nice to know that that is being properly looked at, and for the rural areas, of course, to the east.
Yeah, and that is a really important point. I don't know whether Becky wants to come in, because we have commissioned external support, Martin, to help us do that. Because again, it's not easy stuff to do. But I have seen a draft of all the consultation materials, and it's very comprehensively covered. But Ellen, do you want to come in? And Becky's not.
Yeah, I'll come in. So. Yeah, as you said, it is quite a complex area to do properly, and we've commissioned the support of another hospitals trust actually who've set up some expertise around this, and they've done a very comprehensive travel impact assessment and indeed our equalities impact assessment and so on. And those will be presented in full in October, attached to the Fit for the Future consultation. So I think you might have seen a shorthand reference to that, but it's certainly not just like focused on some geographies. It's taking account of all of the populations across the county, both rural and urban, in that analysis. Does that answer it, Martin? Happy to go into a bit more detail if that doesn't.
If we're going to get both those assessments in October, that's great. Thank you, Anna.
Okay, thank you for that, and thank you, Martin. Right, we're going to move now to Terry Hale, who's got a question. You're on mute still, Terry. Terry, you're still muted. That's better. No, you're mute.
It's not been answered. Yeah, thank you.
Okay, thanks, Terry. Right, that means I think we can go to Paul Hodgkinson.
Yeah, I mean, I won't take up much time, because actually Martin Hallwood basically said what I was going to say, which is that there's still a lot of concern in the community in the Cotswolds and Cheltenham about the future of Cheltenham's A&E, the longer term future, and how difficult it might be to bring it back if this goes on for a very long time with the current changes. So I just want to reiterate what Martin said. I'm glad to hear what has been said by our NHS colleagues today. That's all on record. So, but again, to flag that sort of the scepticism out there and the need to get Cheltenham A&E back as soon as it's practically possible. Thank you.
Thank you, Paul. I think we've obviously had the assurances today, which hopefully will help in the committee's thoughts as well. Right, I've got Stephen Hurst who wants to ask a question.
Thank you, Chair. I've got two questions or two subjects. The first one is regarding stroke treatments. Looking at the presentation, it would appear that we have, for want of a better term, simple stroke treatment at Cheltenham and severe stroke treatment at Gloucester. Have you ever considered having a centre of excellence for strokes at Cheltenham Hospital, which would mirror the success that we've had at Dursley, where we have another centre of stroke excellence for recovering patients? So has that been considered?
Mark, do you want to comment? Because I think there's probably a little bit of misunderstanding, forgive me, Stephen, of the model, very, very much as you describe, actually. Mark, do you want to talk about that?
Happy to comment. So We haven't separated the treatment of stroke, so everybody comes into Gloucester and receives their initial treatment in Gloucester. The move of the acute stroke unit rather than the hyperacute stroke unit to Cheltenham was something that a decision that we made in order to help manage our patients during COVID. And actually, we're learning quite a lot from it. So once we come to the end of the temporary changes, we will review the learning, and that is being fed into all of our planning for the future. So I don't want to prejudge the outcome of any learning that we get from this current configuration of services, but only to assure you that where we've had to reconfigure services in order to manage COVID, we will, of course, learn from that, and where it works, feed that in, and where it doesn't work, make note of that. However, the stroke pathway remains the same. If you have an acute stroke, the ambulance brings you into Gloucester. You're assessed by the stroke team in Gloucester. You spend a short period of time, 1 or 2 days, on the hyperacute stroke unit, and then, assuming your COVID swab is negative, are moved over to Cheltenham to the acute stroke unit as soon as possible.
Thank you. My second subject is about 18 months ago, we had a radiographer emergency. Now that our minor injury units are reopening, have we got over our X-ray emergency, and X-ray facilities will be available where they were in those minor injury units?
Councillor Hurst, I'd like to have a more positive response to that, but unfortunately, the very high levels of vacancy that we had that prompted the initial changes persist. We have had some small success with an overseas recruitment, but our vacancy levels are still, at the last data I saw, they were still at 17%. We will take stock of what we're able to provide as the minor injury units do open, because you'll be aware that some of those that are open have still got slightly revised hours, for example. But regrettably, despite best efforts, we still do have considerable issues in relation to radiographer availability. What I would stress is that there is significant interest in our Fit for the Future programme around interventional radiology, which would put the trust at the front end of delivering this model of care, which we hope might attract staff that would otherwise perhaps look at Birmingham or Bristol above Gloucestershire. So I think in the medium to long term, it's looking more promising. But right now, I'm afraid the vacancy levels are pretty similar to what they were.
And that's sad to hear, isn't it? But hopefully it will improve.
Let's hope so. We're certainly working hard. And as I said, the overseas recruitment, it's a particularly kind of positive green shoot, but it's early days.
Okay, thank you.
Thank you, Stephen. I think that's the end of the questions that we've got on this item. So we are now.
Colette is waving.
Colette, sorry, I didn't see you on the list, but yeah, you come in.
Sorry, I'm just trying. Oh, gone.
You can go ahead now.
Yeah, sorry. I can't get through. Stuff you've gone off.
Yeah, we can hear you.
Oh, can you? Oh, that's great then. Yes, it's really for Mark Picconi, this question, please. Regarding undiagnosed, I'm very concerned about undiagnosed and underlying health conditions, and how many unnecessary deaths have occurred in the county due to COVID and appointments that never happened. I also note that heart attacks during that was up by 40%.
Thank you for at the moment, we're unsure as to the answer to that is the honest truth. And the answer to that is more likely to come through public health route than through the trust route. You will see starting to get analysis about excess deaths related to conditions that were not COVID related. It's a very real concern that patients will either with acute conditions such as heart attacks and strokes didn't present during the COVID pandemic, or that patients who have conditions such as cancer, for example, presented late. What I can tell you is that we have some of the highest levels of delivery of the 2-week wait referral system in the country, and that for the first time in many, many years, we're meeting the 62-day referral to treatment target. So I don't want to minimise it as a problem, but I would like to provide you with some assurance that in Gloucestershire we're doing at least as well as anywhere else around cancer in the southwest or in the country. To your broader question about when this is all done and dusted, where will the excess deaths come from? Will they come from COVID, or will they come from delays related to seeking treatment from non-COVID conditions? We don't know the answer to that yet, but that analysis is really important, because it's something that we will need to learn from for future pandemics. And I'd point you in the direction of Sarah and your public health team, who will get that data before we do in the trust.
Okay, thank you very much. Thank you.
Thank you. I think that is an interesting response, to maybe something the committee may want to take forward to look at again once we've got more data there. Martin, you've got your hand up. Have you come back with another question? No, it's gone down now. Okay, right. I think we've reached the end of that item. So,
sorry, I'd muted.
Okay.
No, there was one thing. It's just the point I made during my earlier remarks, that it would be nice to have an actual plan for the service restoration of the A&E at Cheltenham. Obviously, that can't be timetabled because we don't know when the temporary measures are going to come to an end finally. But just perhaps outlining what conditions need to be met for that service to be restored and how that might happen in outline. And perhaps we could add that as a condition of our approval of the 6-month extension of the temporary measures.
Yes, okay, Martin. I think we can take that on board.
It's a very reasonable ask, Martin. We've got that. We've got the bones of that, as you would expect in any event. So yeah, very happy that we include that in a future meeting.
Great, thank you very much.
Thank you, Deborah. Yeah, so we've got that assurance and obviously an interesting point. So we are noting a 6-month extension this time to the temporary changes, and hopefully when we get to the end of that 6 months, we'll be moving back to normal, but who knows? We're in interesting times in that sense. But yes, a plan for that direction would be beneficial. Right, so thank you very much for everybody for contributing to that item. We're now going to move to the last agenda item, which is the performance update for the clinical commissioning group, which I think is Mary presenting that.
Okay, I'll start, and obviously colleagues can chip in if there are particular questions and answers. So you'll see that we have had a real impact on our performance as a system, across the whole system, due to COVID. We are constantly reviewing performance, and I want to highlight a number of areas where there have been updated figures in the last month since this report was produced. We are now seeing a return of people to services. This is exactly what we wanted to see, and it is encouraging, and we want to continue to communicate to the public and encourage them to increase their confidence in services. And we've talked today a lot about how we're planning to working hard to keep our services safe for people to access. So I wanted just to start with cancer services, which we've talked about many times in this meeting before. And we're starting with the 2-week wait performance on cancer. We reported last time that we achieved the 2-week wait target with strong performance. And in the report this time, you'll see that we're continuing to achieve the 93% 2-week wait target, and activity is increasing steadily month by month. In the report, however, we do highlight areas where we have concerns. We're monitoring this at a much more granular level, and we can see that there are the 2-week wait referrals for lung cancer are still 40% down on last year. That's a piece of work that the group who are working on cancer pathways are working through. Skin referrals are also down, and that's a concern. Of course, last year we did have a significant spike. You might recall discussions last year in the summer around skin referrals. That will obviously be a comparison to a very high level last year. We need to work to increase the 2-week wait referrals, so people are coming forward. The really good news story that I want to report today, and I'm sure Deborah will want to answer this, and Mark, Tony, everybody, is around the 62-day target, where where at least 85% of patients need to start a first treatment for cancer in 2 months, 62 days. Now we have worked on this target for many years, and we were delivering in July 87.7. And now the trust has moved to 87.7, and that is higher, much higher than the national performance, which is about 78.4%. So it's really good news that people who are sent in through the are getting their treatment within 2 months. The first treatment for cancer within 2 months. It's an amazing achievement for Gloucestershire. So I think on other areas, just to mention dementia diagnosis, we are just working through why we're not achieving this target. We're a small distance away from target, but there are some issues we need to work on. You'll see that on IAPT, I know that you're always interested in mental health targets. We have shown a recovery trajectory where we've gone from May at 44.3% to achieving the target at 54.5% in June. And diagnostics, again, there's been a national dip in diagnostics, but again, that's an area that this system's doing well in, and that's showing a steady improvement. And 4-hour A&E remains below the target, but you've heard today quite a lot work on winter plan and the focus around making sure that we achieve the best target possible in 4-hour A&E for our population. So I want to stop there. I don't wonder if any of our trust colleagues want to comment on just some of the work they've been doing to achieve some of those targets. It might be useful to hear from them.
Thank you, Mary. I haven't got anybody else indicating. Does anybody else want to come in and comment before we go to questions?
If I could get off my mute. Yeah, Brian, I wouldn't mind just my moment on the cancer 62-day standard. As Mary said, it's been a cause of great celebration in the trust. I put in the chat there, June 2014, when we last achieved this standard. So it has felt like my own kind of leadership holy grail to address this. And about a year ago, we were achieving across all our service lines, with exception of urology. And it's been urology that really has been our Achilles heel all the way through this journey. So I do just want to pay kind of public tribute to the clinicians and managers and administrative staff that have worked together in a very different way to achieve this standard. And as Mary said, we've achieved it now for 2 months, and those improvements really are embedded around different ways of working. So I'm confident, and I don't say that lightly, that we'll continue to see this really strong performance. But it has just taken such a lot from individuals at a time when, as you can imagine, they were already being asked to give an awful lot. So yeah, really did just want to publicly acknowledge the colleagues both in the service, but in our labs, in radiology and imaging, because this has been a whole hospital effort, and some phenomenal leadership from people in my team.
Thank you, Deborah. That really is good news that you're able to report there. So that's excellent. I've got a question now coming from Martin, I think. Would you like to put your question, Martin?
Yes, and joining the congratulations to your team. Really, it's great that those targets being met, both on the 62 days and the 2-week wait. But can I just ask a kind of statistical question, really? Is it not going to be much easier to reach those targets because of the low level of referrals? Is there not a risk this is a slight statistical phenomenon? I don't want to take away from the achievement, and I'm as I said, genuinely congratulate your teams on the achievement of this, but it
almost snatched
could it
defeat
not
from
be
the
a
jaws.
statistical?
Almost, Martin. Almost snatched defeat from the jaws of victory. But if I know anything when I come into a hospital meeting, it is that Martin Horwood will have been all over the statistics. So I can assure you that this isn't achievement because of what's happened around low demand. In fact, as Mark's alluded to, we've managed to maintain an awful lot of demand, and since early June we were at 80% of former demand levels, and on a 62-day pathway we're talking about a very contemporary data set. So no, demand is as it historically has been when we're looking at this improvement. So it really is a great achievement.
But on page, sorry about this, but on page 21
just note before we do a data dance, Martin, can I just note that I know it's not helpful, but we're looking at June's data here in terms of the detail, and the narrative we're talking about is July and August.
Oh, okay. So it's gone up from that 1883 that was reported for July. Oh, excellent.
Dramatically,
that's really good. Really good.
It really is.
It really is good. Okay, that's fantastic.
Thank you, Martin, and thank you, Deborah. Clearly, councillors have to have a healthy scepticism of things. Obviously, we also need to be make people think it turn out well. So
we are stronger for the challenge, without a doubt.
Okay, I don't have anybody else indicating to speak. If you do want to speak, quickly make yourself clear. If not, I think that's probably reached the end of the discussion regarding performance. So thank you, Mary, and the rest of you for bringing that forward. We have a committee, as a committee, noted that, so thank you very much. And that brings us, I think, then really just to discussing our work plan. So I will thank everybody for attending the meeting, and thank you very much. And we'll see everybody in October for our next meeting. Thank you. Now, if we move on for committee members to the work plan. Joe, do you want to come in and just refresh people's views on where we are with the work plan? We've got a request for the question on phlebotomy, and siren testers blood testing situation to be brought onto our next agenda. Is that something the committee supports? I'll take that as a general yes, because you're not able to say. And I've also got Steve wanting to come in. Steve, do you want to come in?
Yeah, right. Just two which have been lying around for a bit. The whole issue of, and I don't want too much work put into it because I know people are busy, but the whole issue of health inequalities, particularly in light of COVID, and what ongoing plans we've got to tackle that. That would be one for me. And the other one is the whole issue about vaccination levels and immunisation levels. That may get reported to the other committee, but I think there's a real concern from many of us that if or when we get a COVID vaccine, we really do need to all work on motoring to get the vaccination immunisation levels up. And we've got certain pockets in and around, certainly I know in Stroud, probably elsewhere in the county, where people are quite resistant to having MNR, for example, and all that sort of stuff. I mean, personally, I'd welcome a longer debate and discussion about what more we can do. So that's it from me on that, sir.
Yeah, it's Sarah Scott. Can I come in there and perhaps respond to Stephen's points?
Yes, certainly, Sarah. Do that.
The issue of inequalities is a really important one. The Health and Wellbeing Board have debated this recently, and my team continue to lead on this. The Director of Public Health annual report that will be published at the end of this month, beginning of the next, focuses specifically this year, always has a health inequalities theme, but on the inequalities experienced by the BAME community as a result of COVID. So we'll be taking that to the Adult Social Care Committee, but I'm really happy to bring that here for members to look at and to scrutinise and to respond to questions if that's helpful. I think the broader issue of inequalities, just as COVID landed on us, we obviously saw the 10-year report of the Marmot Review, which is a really, really important report. And it is still on the agenda for the Adult Social Care Committee to take forward quite a detailed report looking at the impact of the Marmot report 10 years on in Gloucestershire. The work on that report had to be stopped because of COVID, and my team is still spending around 90 to 95% of their time on COVID response. And that's likely to continue until about next May at the earliest, I think. And so there will be some time before we'll be able to do some broader work on inequalities, but I'm happy to share the DPH annual report with the focus on the BAME communities if helpful.
Thanks,
and the other
Steve.
issue about, can I just mention the issue about vaccinations and immunisation? So I think if we're going to do an in-depth piece of work on that, then it might be worth talking to colleagues in Public Health England and NHS England who lead the commissioning of screening immunisations. I get regular reports on uptake and the work that they do to address the inequalities in uptake, but I completely take your point, Steve, about some of the anti-vaccination feelings that we have across the county, and we do need to do some considerable work, I think, as a system to promote the COVID vaccination when it is available. But I think we would probably need to do a bit of a double act, perhaps between my team and Public Health England and NHS England representatives. But at the moment, I don't think I'll be able to support that this side of Christmas, unfortunately.
Great.
Just because of the COVID workload.
Great. I'm also keen on how we can legally compel people to do it, but I know that's a wider topic.
Yeah, thank you, Steve. And clearly that is an issue for that we perhaps need to talk about how the vaccine programme comes forward. But probably that needs to come in when we know what we're dealing with in terms of a vaccine. I can see Becky wants to come in on that. Julie, is that on that topic, Becky? Okay.
It was about the phlebotomy item, actually. I wondered whether or not members wanted to have that at the extra meeting we're having in October, which I think is going to be quite a heavy agenda with the Fit for the Future and the Forest of Dean consultation proposals, and whether or not committee members might like the phlebotomy item for the previously scheduled November meeting of the committee.
My suggestion would be that we probably go for the next scheduled meeting, which would be November, and we stick with the extra meeting covering the two items that we've got on, as you say, which are quite heavy, and that would be the normal next meeting. So I think that's still sort of addressing the principle of what was requested there.
Thanks, Brian.
Okay, I've got Martin with his hand up. Did you want to come in? Martin Horwood?
Yes, yeah. Yes, thanks. Sorry, I was just trying to unmute myself. If we're just on the broader work plan, just first of all to remember the point from earlier on about I guess it's about the committee's configuration and public health. I mean, I think this epidemic has really demonstrated how you can't separate health from public health, and how sort of intimately they overlap. I mean, obviously, the clue is in the name, really. So I would like us to revisit that. And it's about a year or so, I think, since the reconfiguration of the committees. So perhaps it is timely anyway to look at that again. And I can say personally, I really value Sarah's input into these meetings. And I think we're very lucky to have a public health team in Gloucestershire who are so on top of things. The second one is just on a mental health issue. And I'm not quite sure where it's got to. It was launched, I think, before all this craziness unleashed on us. So I don't know whether it's been blown out. But it was the pilot on mental health in schools and looking at school environments, which I thought was really important. And where a number of schools were being originally talked to, I think, by Together in its previous incarnation, but as part of a national sort of project. And I don't know where that's got to, and I haven't heard about it recently. So maybe Mary can update us now briefly. But I just thought it would be a good thing to have on the agenda. It's not a. Well, I mean, it is an urgent issue, but it's not a particularly urgent one for this particular meeting or October. But I think we ought to have it in the work plan somewhere, because I think mental health in schools is a huge issue, and probably even more so post-pandemic.
Yeah, thank you, Martin. Yes. I think you've raised an interesting point regarding the committee. That I took over chairing this committee after it was after the sort of adult care and community committee was set up as a separate item. So I wasn't part of the discussions that drew it up that way. I don't know if Sarah or one of us, Joe Moore, is able to give
Can I come in, Brian?
Reason. Yeah, Joe, do you want to give a sort of background as to why we did it this way? Clearly, we don't want to duplicate work, so we don't want two committees doing the same thing.
Suggesting we put it in the work plan, not necessarily discuss it now, but anyway.
Yeah, I have a suggestion. We do have Councillor Stephen Hurst, who is the chairman of the Adult Social Care Committee, on this committee. Just going forward until the matter is reviewed, it could be that we ask Stephen to just sort of update the committee on any points from the adult social care meeting that has taken place. And I could put the link to the papers on the agenda for this meeting, so that you've got an item that if there is anything that you have a concern about from the public health issue, that you could actually address at these meetings. I understand that the decision was taken by the county council that the agenda for the joint meeting of health and adult social care were just so heavy, that the workload was so heavy that you couldn't actually get through everything in one meeting. So they separated the agendas, but there's nothing to stop you linking the two that you can still reference to. So that's just a thought.
Yeah,
I don't know if Steve,
I think that's what I'll take away
wants
offline
to
to discuss, because the point about mental health in schools is also of interest to the Children's Scrutiny Committee, obviously, and so finding the right balance between which committee reports it and how we make sure that a wider number of councillors can be engaged, even if they're not necessarily on the specific committee, is something I think we can take away to look at, and I'm sure that's something that we would all be wanting to progress. And at the present time, I think everybody can see that this, if you're looking at health, you've got to be looking at public health because of the significance of what's going on. So I think we all understand that question, Martin, and perhaps need to discuss it in various places. But thanks. Are there any other points that people want to put onto the work plan?
Chair, I think Mary was perhaps ready to respond in part to one of those as well.
Right, Mary. Right.
Yes, I put a note in. Actually, quite a lot of staff have been recruited in the mental health trailblazer. That work is continuing in a slightly different form during COVID. But actually, that's a really exciting project, actually, and we're looking at how we can continue that for the future.
Thank you, Mary. And Stephen, I think you want to come in as well.
Yes, thank you. I was just going to make a point that it's now 12:30, and we've been talking about health in a medical sense for 2.5 hours. And if we were to add adult social care onto this agenda, it would just be impossible. So today's meeting is an example of why there should be a division between adult social care and health care. Now, what we do is, in fact, if we take the COVID example, we talk about COVID treatment in a hospital and a health setting, and we talk about in an adult social care setting, and what we get is a far deeper discussion and understanding of both settings. Thank you.
Yeah,
thanks,
Stephen. Didn't actually suggest putting adult social care on our agenda.
That's where we were, I think, a year ago before we made the changes. But obviously, as we find ways of improving it, we'll probably be taking those, and everything has to move along, because we need to work with the other committees to deliver scrutiny across the whole agenda. So I don't think we've got anybody else wanting to cover the work plan. So we'll take away the points made, and Joe will be trying to fit that in as well as possible. So thank you all very much for coming along today, and we'll see you all in just a month. So.